Hello, I'm Kevin Proud, Associate Professor of Medicine, UT Health San Antonio, and this is a short video talking about performing and interpreting lung ultrasound. We'll start with talking about the equipment settings. So on your ultrasound machine, most people do the lung exam in the abdominal setting, although machines do have a lung ultrasound setting, but that setting tends to appear more grainy and difficult to interpret, particularly when you're looking at pleural effusions. We typically do this in the radiology convention, which means that the orientation marker is on the left-hand side of the screen, which correlates with the orientation marker on the probe being pointed either at the patient's right or towards the patient's head by convention. You want to make sure that you have adequate depth, which for most cases is going to be around 14 to 16 centimeters. Have to be more deep for larger patients, maybe a little bit less depth for very thin patients. As we'll talk about, you can use different transducers. When you're using the linear rate transducer, I don't think there's really a preferred setting. I think either vascular or soft tissue settings work. For the lung exam, there are a multitude of different transducers that are useful. You can use a curvilinear transducer, which has a very wide footprint, lets you see a lot of the thorax at once. Probably the most commonly used is the phased array transducer. Again, both of these are low frequency probes, so give you more depth, but at a consequence of sacrificing resolution. At some places, the microconvex probe is favored because it can fit down into the intercostal space. Lastly, you can use a linear rate transducer that is a high frequency, high resolution transducer. The issue there is you sacrifice the ability to have more than about 5 or 6 centimeters worth of depth. So it's not all that useful for looking at pleural effusions or deeper down into the lung for other signs of pneumonia. The two main transducers people use, I would say, is the phased array is the primary tool, particularly in the US, and the linear array is most commonly used when you're heavily looking for the pleural line, looking for pneumothorax, and need that high resolution to definitively see things like lung sliding. When we do the ultrasound exam, we hold the transducer like a pencil. You want to be perpendicular to the pleural line and the chest wall. The chest wall and the pleural line are not always completely parallel, so sometimes it requires a little bit of tilting or rocking to really be as perpendicular to the pleural line as possible. We put the orientation marker typically towards the patient's head so that we always know where we're looking by convention on the ultrasound image. If you're not getting a pattern of A lines or B lines, the key probably is to tilt this probe back and forth to get as perpendicular to the chest wall or the curvature of the pleural line as possible. When it comes to where to look with the lung ultrasound, there are numerous protocols out there, and I don't think one is definitively better than another. In many cases, it depends on how much time you have to scan and how much detail you need to look at a specific structure. In general, they are divided into 3 sections, so anterior, lateral, and posterior. Some protocols can be as few as 6 points per lung, meaning 1 or 2 rib spaces in each of these zones, to something as thorough as scanning the entire rib space, moving down one, and scanning the next rib space until you cover the entire hemithorax. You can do the exam with the patient lying flat, or potentially even better with them sitting in the semi-recumbent position, so you get a better view of that posterior wall. In some cases, if they can roll over slightly away from you so you can get more posterior, it's helpful. If not, we really need to push that transducer down behind them, what we call knuckles to the bed, so that the ultrasound beam comes back forward and you don't miss any small findings down at the very base of the lung or very posterior. Typically, we'll do 2 to 3 intercostal spaces per anterior, lateral, and posterior zone. Again, you really want to see that area at the lower portion posteriorly because that's where the majority of the pathology is. This is also in the lateral and posterior portions are where you will also see the diaphragm. I always try to remember to think about using the ultrasound or thinking of it like a flashlight, and the ultrasound beam is where you're pointing the light. So try to imagine where in the patient's body the ultrasound beam is going if it's coming straight out of the transducer. That way you can think about how anteriorly you're pointing the beam when you get the transducer more posterior to them or underneath them and look forward. Just to help you understand orientation, remember at the top of the screen is going to be closest to the transducer, which will be the patient's chest wall. So your flashlight's pointing down. So at the bottom of the screen, you will see the deeper structures, deeper into the patient, near the bottom. Toward the left of the screen is going to be towards the patient's head, if you have the orientation marker and orientation lined up correctly. And then to the right of the screen will be towards the patient's feet. When you do the lung exam, you're trying to identify one of 3 or 4 major patterns. So A lines, which are recurring horizontal lines distal to the pleura. You want to look at that, whether or not there is lung sliding at the pleural line. You want to look for B lines, which are big vertical lines that start off at the pleural line and go down all the way off the screen and move with respiration. You also want to look for consolidated patterns in pleural effusions. So I'll show you some quick examples of each of those. So this is just an example of A lines done with a phase array probe. So you see the pleural line just deep to the ribs and the rib shadows here, and the A lines are these recurring horizontal lines. You can see this shimmering motion. That's the 2 pleura, the parietal and visceral pleura, sliding along each other as the patient breathes. Helps you exclude a pneumothorax. This is another example of those recurring horizontal lines, or A lines. Here's the rib, followed by the rib shadow. The pleural line is always within ½ centimeter of the front of the rib. You can see in this example that that pleural line is not shimmering and sliding back and forth. There is some movement from the patient trying to breathe and their whole chest wall moving, but that is no shimmering or sliding, suggestive or consistent with pneumothorax. This is an example of those vertical B lines that start at the pleura and they move back and forth with respiration. They go all the way off the screen, and if they were to run into the occasional A line, like right here, the B line should obliterate the A line. Here's just another example of more B lines as they start to get wider, thicker, and start to coalesce. Next pattern is going to be the consolidative pattern. So again, orientation-wise, to the left of the screen is towards the patient's head, towards the right is towards the patient's feet. This big structure here in the center is the liver or the spleen, with the diaphragm coming up here. And this triangular, more dense structure is the lung that's consolidated with some bright white air bronchograms in the center, and a slight pleural effusion up here and down here. Just another example of a consolidated lung. So you can see spleen over here, big consolidated lung here with some of those white dots that move with respiration, known as dynamic air bronchograms. Here's just another example of a consolidated lung. We're looking in the left upper lobe for reference, as it is labeled here, and you will know as you're actively scanning the patient. And where you should see A lines or potentially B lines, you see a rib space, and in between that rib space, a very dense area with some bright white air bronchograms. So this is another consolidated pattern. This is just to show you there can be some variation. We had a patient with COPD and pneumonia. In the video clip, you'll see that I start with the transducer in a more aerated portion and just slowly move up the rib spaces. So you see we start off with the A-line pattern as we go here, and we go up a little bit. We start to see some B lines from this pneumonia starting to develop. Go up another rib space. The B lines get a little bit more confluent where the pneumonia is a little bit more severe, and then finally get up to a higher left upper lobe area where we start to see that consolidative pattern. I slowed the image down and went back and forth a couple times to show you that transition point from the B lines to the consolidative pattern. Lastly, you can see pleural effusion. So in the upper video, you see the diaphragm or spleen, the liver or the spleen, the hyperechoic diaphragm, and then this big anechoic area or fluid collection here with some consolidated lung floating in it. This bright white stuff down here is actually the spine that you can only see above the diaphragm because there is now an acoustic window due to the pleural fluid located there. On the bottom video, you see the spine below the liver and the diaphragm, but you do not see it extending above the diaphragm because there is no pleural effusion in the bottom video, and the aerated lung scatters the ultrasound beams, so you're unable to see there. So this is like a curtain sign or a spine sign, because anytime you see the spine above the diaphragm, there has to be some kind of density other than air density that's carrying the sound waves down there. Thank you very much for your attention, and happy scanning.